The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerreview.com/DJX860. Downloadable slides and practice aids are also available. Thank you for listening to Peerview Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hello and welcome to Building New Management Models for Non-Hodgkin's Lymphoma Care, Tumor Board Insights on Innovative Therapeutics in Follicular Lymphoma and Large Cell Lymphoma. My name is Nathan Fowler from the MD Anderson Cancer Center in Houston, and today I'm really honored to be joined by an all-star cast of my colleagues, including Professor Martin Dreiling from Munich, Dr. Karen Jacobson from the Dana-Farber Cancer Institute in Boston, and Dr. Krish Patel from the Swedish Cancer Institute in Seattle. So today's agenda is very straightforward. This is going to be a seminar and some tumor board sessions focusing on looking at what's after or coming after chemotherapy. Are there better versions of treatment for relapsed and refractory follicular lymphoma? What are the latest developments? We'll then move to talking about the emergence of novel antibodies in large cell lymphoma and conclude with the present and future of some exciting CAR T-cell therapies in non-Hodgkin's lymphoma. So with that, we'll launch right into it. And again, I'd like to introduce a colleague and personal friend, Dr. Professor Dreiling from Munich, who's going to be talking about building a bridge between chemotherapy and follicular lymphoma. Dr. Dreiling.
Well, thank you very much for this kind introduction. You might say, well, this is a boring thing. Talking about follicular lymphoma, this is solved. Well, it's not really solved, because if you have a look at this slide, which shows you the clinical course in first line shown in the greenish curve and in relapse disease, first and second relapse in blue and red, you see that median PFS in relapsed follicular lymphoma is only in the range of less than 2 years. And therefore, although this is indolent disease, we definitely need some improvement. So let's have a look at the guidelines. What's their recommendation? And here we have the recommendations for first line. Essentially, it's a choice of R-CHOP, R-Benda, or combination with Obinutuzumab, or R-square. And if you have a look at the recommendations for first relapse, it's pretty much the same, to be honest. However, what you also see at the bottom line, there are some additional features, some additional chances which way we could go. So the question really is which way to go. And if you see this broad variation of options, there is not a black and white selection, but it's really, a spectrum of options, and we have to decide for the individual patient which one is the best. So let's bring that to real life. Here we're talking about a chat from our own outpatient department. Patient at first presentation in the age of 70 years almost. Interestingly enough, during the workup, we also diagnosed prostate cancer. But anyway, he was in a reasonable, good performance status. We started with bendamustine rituximab, which probably is somewhat the standard in most countries meanwhile. And he achieved a good partial remission that was only based on CT scans at that time, and relapsed after a couple of years, 3 years in fact. Which is rather early for bendamustine, to be honest. And then we moved on to a CHOP salvage treatment, and again he relapsed rather early, now within only 1 year or so. Now here we are at the setting what to do. Well, first of all, it's fair to say watch and wait is also standard of care in relapse disease. So first of all, We just, observed this patient, but that didn't help for a long time because patient showed significant enlargements of mediastinal lymph nodes with vascular compression. So now we have to act. And that is really the question, what to do in this specific patient. And here I would really ask my esteemed faculty colleagues, let's start with Nathan. So Nathan, how would you, what kind of treatment would you pick in this specific patient? Now we're talking about a patient age 75, and why?
So thanks, Martin. This is a bit of a tough case. This guy, I'm concerned. So although he had a okay remission, as you mentioned, after BR, after R-CHOP, really didn't last very long. In fact, it looks like he's kind of got rapidly growing. He's got a almost 6 centimeter mass, within not long after CHOP. So the first thing I'll do is biopsy this guy and make sure he's not transforming, right? Because something has changed about the kind of the way this thing is behaving. But assuming this is still a low-grade follicular, if his ECOG is still good, I would really lean towards. Well, I love R squared, so I probably would lean towards R squared in this gentleman. And but I'm a little bit concerned about the rapid change in the disease. So even if he responded to R squared, this is a guy, if he's right on the border of even maybe considering something like transplant as consolidation, because he's So R squared is the short answer to your question.
And fair taken, just to add on that, we did a biopsy exactly for the reasons you said, you mentioned, and it was again only follicular lymphoma grade 1 and 2, but this is really underlining the role of rebiopsy. Any comments by the other members of the faculty? Krish?
So I also agree. I think this is a good candidate to move away from chemotherapy and towards drugs that work by different mechanisms. And I think R squared makes the most sense. It's also someone you could consider for clinical trials at this point. It's always a right answer when you're dealing with a disease that's not behaving the way you expect it to.
Yeah, I'd agree with what's been said by Dr. Jacobson and Dr. Fowler. This is a patient where often we're talking about a treatment option, but also anticipating something coming down the road. So as you mentioned, maybe that's a transplant, maybe that's a clinical trial to prepare for. So agree with what
Okay, so let's say what the options are today. If we have a closer look at this patient, so what are the options nowadays really with chemo-sparing combinations? And I really would like to move on the first option Nathan mentioned, which is R square. What are the hard data on R square? And for myself, the most convincing data are shown here. A large study with more than 1,000 patients. And Nathan, you were one of the chairmen. And what you can see, these two curves that was comparing our chemotherapy standard, which is namely R chemo followed by R maintenance, comparing to R square, and you see these curves are totally superimposed. So no difference at all. So now it really depends how you evaluate these data, whether you're an optimist or a pessimist, because formally the study was negative. But wow, this academic-wise is the first study showing that a non-cytostatic approach achieves exactly the same like the good old R-CHOP standard. Now, based on this study, John Leonard performed a study in relapse disease. Again, a multi-center trial, international trial, really representative, and now comparing R versus R square. Now you might say, well, R mono is not my standard of care in first relapse, but that is how the study was set up. And let's have, first of all, a look at the side effects. Not surprisingly, we have seen slightly more toxicity in the combined arm. And that's mostly neutropenia. However, if you have a look at the infections, at least the rate of severe infections was only, increased by a small range. So what about efficacy? Well, not surprisingly, 2 drugs achieve more than 1 drug, but what is quite interesting that this is not only statistically significant, but this is really clinically meaningful with a benefit in the range of 20+%. And what is even more convincing, that this also translates into a borderline significance when it comes to overall survival, at least for the group of follicular lymphoma. What does that mean? If you use R instead of R square in relapsed follicular lymphoma, you will not be able to catch up later on by whatever kind of salvage treatment. So really compelling data, and based on that one, R square is nowadays registered in the most Western countries. And if we look into the future, and these are the European guidelines which have been just submitted and now they're in press, how do they list R square? And I have to explain that our EHA ESMO guidelines are a little bit more restrictive. We really would like to give advice to our colleagues. And what you can see is R square is being listed there also in first relapse, in fact, and specifically for the early relapses, which makes perfect sense, because if chemotherapy doesn't work in first line, why should it work in second line? And secondly, I think it's really the current standard of care in third line, because if you have a look at the different options, including other monotherapies, and here Rituximab monotherapy definitely is a standard of care, this is really the most efficient approach. What you also can see here in the bottom yellow frame or orange frame, PI3K inhibitors. And these so far were only recommended for double refractory cases. Why is that? Well, first of all, if we look at PI3K inhibitors, what we know is that they really block multiple pathways. And that may be in fact the reason why they work so good. Meanwhile, we not only have one compound, we really have a couple of them, and I really would like to have a closer look at these different compounds to really try to explain what are the differences between these different approaches. So first of all, this is the study on IDELA, and the important point is really saying this is not your standard follicular lymphoma, these are double refractory cases. So we discussed in our patient, remissions were rather short, but these are really patients relapsing within 6 months, so even more aggressively. And what you can see is in fact that you see a shrinkage of lymphocytes in the vast majority of cases. And formally, the overall response has been observed in a good half of these patients. So why don't we treat patients with PI3K inhibitors all over? Well, there was a disadvantage, and that initially was overlooked because it occurs just with a delay of, well, a couple of months. And that's concerning infections, but specifically also autoimmune regulated colitis. And in the initial trials, some of these patients died of this toxicity because we were not experienced to handle that. Meanwhile, we have a follow-up compound, which is Duvelisib, also showing high response rates in double refractory cases. When it comes to toxicity, it's in a similar ballpark as IDELA. So both of these compounds have received a black box warning by FDA. However, if you're able to handle these toxicities, if you experience, patients may really profit of these approaches. So which way are we moving? What are the new ideas flying around? And I really would like to, as a starting point, stay with PI3K inhibitors, because there's another compound which is also registered in US, which is Conjugates. Well, practically it has differences because it's been applied IV, and therefore it's been applied based on an intermittent dosing. So let's first of all have a look at the toxicity, and what you can see here is a list, on the bottom, the typical toxicities we are afraid of with PI3K inhibitors, pneumonitis and colitis, and also liver enzyme elevation. And what you can see is there are hardly any grade 3, grade 4 toxicities for copanlisib. So obviously, concerning these side effects, it's much easier to apply. However, it's fair to say, and that's based on its alpha isoform inhibition, that we do observe hyperglycemia and diarrhea, diarrhea only to a small extent, but hypertension and hyperglycemia only for a very short period right after infusion. So this is gone, let's say, 2 days later. So this is why we routinely perform this kind of treatment on an outpatient base. What about efficacy? It's as efficient as the other compounds, maybe even slightly more effective. That might be due to IV or not. But what is important, we still said in our guidelines, we only reserve that for the double refractory cases. How to move on? Well, how to move on in earlier lines? This is first of all the long-term results. What you can see is for the CR patients, they really achieve long-term remissions beyond 2 years. And that's something in these highly relapsed patients. So I would really say there is a principle, and if you recognize this principle and try to improve and really compare these 3 different compounds, what you can see is when it comes to toxicity, here I framed in green the only temporary effect, short-term effects, and in the red one, the more, let's say, frightening side effects. At least in my patient experience, copanlisib is rather easy to apply. And if we try to move on to earlier lines of treatment, of course, we go into combination. And these are the 2 studies which are currently ongoing. It's a very logical step. Combination with Rituximab and combination with our chemo. Both been tested in a randomized way, and you might have heard just recently that the top of these trials, the Kronos 3 trial, had achieved significant results in that way that the primary endpoint of PFS, so not only response but PFS, has been achieved in favor of the combined arm. So of course we will be very interested to see the final data of this trial, and then we will in fact compare that to the Augment trial and see which one of these approaches is higher efficient and maybe better tolerated. So moving on to a totally different field, which is really EZH2 inhibitors. Well, what is EZH2? EZH2 is mutated in about 1/4 of follicular lymphoma. And what does it do? Well, let's say it keeps the malignant cell in the germinal center. And therefore, there it can survive, and with the additional genetic alterations, specifically 14-18 translocation and BCL2 amplification there, or overexpression, we see these cells are prone to collect additional genetic hits, finally leading to clinically overt lymphoma. And this compound was tested in a trial, which is interesting because here it was on purpose differentiated between cases with and without EZH2 mutations. And what are the results? Well, these are really high-risk patients. I really would like to emphasize the median prior lines was in the range of 2 to 3 lines, and quite a number of these cases were refractory to prior treatment. And what about the efficacy? Here we do have the cases with EZH2 mutations, and you see you virtually achieve shrinkage of lymphoma in essentially all of these cases. What is interesting though, this also seems to work in cases with wild-type EZH2. And we are not quite sure why and how this works, but again you see that in the majority of these cases, 2/3 of these cases do again show some decrease of lymphoma. So I should also add, this compound has a very high tolerability, almost no severe toxicity. It's an oral drug, and so it's easy going for the patient. So the only shortcoming, if you see the final results And this is again split according to the EZH2 mutation status. What you can see is, if we're talking about median PFS, we're only talking in the range of months. Let's say half to a full year, not more. However, based on its favorable tolerability, I think this is a perfect drug to be combined with other compounds. And this is exactly being tested currently. And we will hear some data in the next days on the combination with R-square. And I think that makes perfect sense, and pure oral combination and presumably high efficacy. To sum up, of course, there's one theme which will be in fact covered by the next speakers, but of course the big thing is immunotherapy, and I really would only comment shortly that in indolent lymphoma it's not only CAR T cells, and we'll see the data in detail, but it's also bispecific antibodies which do have a higher response, achieve a higher response rate, but also long-term remissions or ongoing remission. So I think both of them are quite interesting, and we'll see how the long-term outcome of these studies will look like. Getting back to our patient, this is what happened. In fact, at that time we only had our hands at PI3K inhibitors. You see in between we treated him with Pola within a study. But anyway, when he received Idela, typically a couple of months later, diarrhea started. And you have to know, Bavarian patients are very stubborn. They are the Lone Star patients of Germany, let's say. And so he stopped treatment and he said, I don't want anything anymore. And what you see on the chart in the middle, and that is really taken from the original medical starts. You see, after stopping, the patients became better and better and better and well. This is almost impossible in Bavarian patients, and very well. And what has happened there? Well, it's interesting. Obviously, the PI3K inhibitors, pushed an immune mechanism, and we have seen a delayed response in this specific patient, which hold on for a couple of years. And that's, I think, a quite interesting aspect of PI3K inhibitors. To sum up, I think we have to learn in follicular lymphoma in that way that we will not treat all patients in the same way. And it might well be that depending on the individual molecular makeup or whatever of the malignant cells, we treat them differently. We already now have quite a broad spectrum of different approaches, but it's really now again to work on that, which patient benefits the most of which approach. And with that, I would like to finish saying that, well, in relapsed follicular lymphoma, yes, it's an indolent disease, but still, specifically for the early relapses, POT24, we do know that overall survival is only in the range of 5 years. So this is more in the range of intermediate aggressively lymphoma. Non-chemo approaches are the standard of care nowadays, and as guidelines recommend, R-square is in front of PI3K inhibitors, and so far this is really being based on tolerability, fairly to be said. There's no comparison of these two compounds, but I think if we look into the future, the one point is really, well, what about the second and third generation PI3K inhibitors? We'll see the data, but specifically, what about the EZH2 inhibitors? I think they are efficient and they're excellently tolerated, and therefore they have a perfect potential for combinations. And finally, immunotherapy, as to be discussed in the next presentations, will really play a huge role in the setting of follicular lymphoma. Thank you.
Thanks, Martin. That was phenomenal, as always. So looks like we have a couple of questions coming in from the audience. I'll take this one. Actually, I'll throw this to you, Martin. So now that tazemetostat is approved, in the U.S. as well as in Europe, how do you know, or I should maybe ask, does it matter if you have EZH2 mutation, and are you checking these patients? For example, in the front line to see if they have the mutation?
Well, I have to be honest, in frontline we don't do it so far, but because we know in at least some of the patients, they will never be retreated after first line. However, in relapse, this is a totally different story. And yes, I would recommend to check for EZH2 mutations. And my personal bias is, and I think in these cases with mutations, EZH2 inhibitors, namely tazemetostat, is a very hot candidate. So that's really arguable whether to go for R² or EZH2 inhibitors.
Okay. And following up on that same question, I mean, you showed very nicely that there is activity in patients that are wild type EZH2, and does that change whether or not you would use this in, let's say, a third line patient who is double refractory, if they have the mutation or not?
To be honest, in real life, if you played all your cards, let's say patient who is not able to undergo CHOP because of cardiac disease, already received bendamustine and received R², there is not much left. And so it's really the question PI3K or tazemetostat, and let's say tazemetostat so far is the easier going.
Yeah.
However, to be honest, even in that setting, I probably would recommend checking for mutation just to have some guess about the response rates.
So that's really, really good. So, and then maybe I could ask Karen, during the, it's very timely, and unfortunately because of the current pandemic, many of us are thinking differently about how to treat our patients, specifically maybe with regimens that are associated with immunosuppression, significant immunosuppression. Do you think that your practice has changed with the current COVID-19 pandemic, for example, with the use of BR or CHOP?
Yeah, I think for frontline follicular lymphoma, it probably hasn't changed, but certainly in the relapse setting, choosing options that mean fewer visits into the cancer center where patients can potentially get exposed, where more of their treatment can happen at home, where they can stay protected. It's definitely been a move that we've done in Boston for sure.
Sure. And Chris, could I ask you the same question? Has your practice changed? Let's say focusing on the relapse setting, do you use maintenance more or less, or are there any other changes that you have started doing because of the current pandemic?
Yeah, I think very much so. I think patients are perhaps, as Karen mentioned, less interested in having frequent infusion appointments or prolonged therapies. And so I think, we've already been using a lot of R² in that setting, and because that's a time-limited therapy in the relapse setting, 12 months, I think that's the approach we've been able to maintain.
Yeah, it's crazy. Well, hopefully, knock on wood, hopefully by next ASH, we will have different things to talk about, at least hopefully we won't be dealing with the current pandemic. But I'm going to move on and to introduce Krish Patel, who is the director of the lymphoma program at Swedish Cancer Institute, who's going to kind of talk a little about novel antibodies and emergence of some new management models in large cell. Krish.
Thanks so much, Nathan. Just to start and kind of frame some of the topics we'll discuss, just share with you a case of relapse refractory large cell lymphoma from my own practice. So this is a patient who was fairly typical for large cell, in their 70s, and had experienced a recurrence 9 months after the initial therapy. Some comorbid conditions here, primarily cardiac comorbidities, but moderate COPD as well. And so at initial diagnosis, this was a patient who had really advanced stage disease and a high IPI score, so reasonably high-risk large cell lymphoma, was a germinal center type, but no double hit. This patient was felt to be fit for full-dose R-CHOP and received 6 cycles of the R-CHOP, and fortunately achieved a complete metabolic response by PET. But then, as I mentioned, about 9 months later, experienced 15-pound weight loss within a month, night sweats and fever, and really was found to have a diffuse recurrence of disease with multiple extranodal sites of therapy. So this is a patient that often I find challenging in the clinic because these are patients where, historically, these are not patients we've probably treated with high-dose chemotherapy and autologous transplants, but as we'll see, the armamentarium is really expanding for these patients. So I'm curious as to the group's thoughts on how they approach these patients in your centers.
And maybe Karen, I'd love to hear your thoughts.
Yeah. So I think it's troubling when right now our sort of next definitive therapy is really approved in the third line and beyond, which would be CAR T-cell therapy, which I think is appropriate for a fit 76-year-old, but auto transplant, as you said, can be a challenge in a patient this age. And so I think you struggle trying to pick what the salvage regimen should be to treat someone just enough to get them to CAR T-cell therapy, but not enough to cause the significant toxicity, or significant response. So we tend to use regimens that are a little bit better tolerated in this setting, maybe Rituxan with gemcitabine-based combination, and try to get a patient like this to CAR T-cell therapy, or find a clinical trial of CAR T-cell therapy in the second line for these patients.
Okay. And very good. Martin, how about in Germany for these older patients that maybe are not really transplant eligible, relapsing early at the first line?
Well, you have to remember that Germany is a bendamustine country, but if you look at the hard data, bendamustine is not very efficient in aggressive lymphoma. So this is a very frequent, typical case. Thank you, Krish. And I think how we would approach that, we probably would consider Polatuzumab. And the idea is, again, trying to get a reasonable remission as a bridge maybe to CAR T cells. And you might know the official label is Pola plus R plus bendamustine based on this randomized trial. How do we approach that? We start with our Pola, collect T cells, and start then with a full triplet, including bendamustine, only after collection of T cells.
Yeah, so thank you guys. You really hit on a lot of the I think challenges that this patient highlights. And so as Karen mentioned, I think we have this idea in third line about what we would do with a transplant ineligible patient, but how to get them there. And then Martin, as you pointed out, we really have to be very mindful of the downstream therapies we're trying to deliver and minimize things like lymphotoxic therapies. So I kind of share here, this is the treatment landscape for large cell lymphoma, and we have some well worked out pathways. Most of our patients in the front line are going to get R-CHOP-based therapy. About 60% of those patients will be cured. Maybe somewhere around 40% are going to go down the relapse refractory pathway and require second-line therapy. And as we pointed out, for a patient like this who maybe is considered not appropriate for high-dose chemotherapy, we have a kind of a need to really fill that second-line space with something very meaningful, something that either allows our patients to potentially successfully receive CAR T cells as a third-line therapy, especially with the number of CAR T products that we have available in different safety profiles of those agents, or perhaps even more importantly, can we find second-line therapies that don't require our patients to have third-line therapies? I'll also point out even for fit patients, when we go down this pathway of platinum chemotherapy and autologous stem cell transplant, and then even CAR T-cell therapy, depending on how you get there, we now have this emerging need for therapies in the post-CAR T-cells world. So, appreciating that really it's less than half of our patients that have durable CRs post-CAR T-cell therapies, we now have a new unmet need. And so when we put this all together, these were kind of some of the areas that I struggle with in the clinic in terms of thinking about, how are we really going to get people through these points in their therapy. And so second-line transplant ineligible, which is the bucket I think our patient case represents, third-line CAR T ineligible, I think is becoming a smaller and smaller population. And as we have different CAR T products, we have different patient profiles that perhaps can receive CAR T cell-based therapies, but there are going to be some patients who may be ineligible for CAR T cells, or perhaps that's not a practical consideration for logistics reasons. And then, as I mentioned, this post-CAR T cell world. And so, you really hear some ideas of antibody-based therapies and how they might be filling some of these spaces. And the dark blue is meant to represent that we have, probably some some form of solidified efficacy data in these realms, with a light blue showing, these are areas perhaps that are ripe for further investigation. So I'll actually talk about each of these boxes subsequently, and we'll start by talking about non-CAR T-based CD19-directed therapy, talk a little bit about antibody-drug conjugates, and then talk about some of the antibody-based therapies that are in clinical trials, such as anti-CD47 agents and bispecific antibodies. So just to remind you, we have lots of different potential targets in B-cell lymphomas, including large cell lymphoma, that may be rife for development of antibody-based therapies. So here we have our malignant B-cell, and you see there's a number of different cell surface molecules that could be targeted. Many of these already well familiar to you, such as CD19, CD20, CD79, which is the target of polatuzumab vedotin. Novel targets like ROR1, we'll hear at this ASH about VLS-101 in mantle cell lymphoma and large cell lymphoma. CD30 expressed perhaps in a small subset of large cell lymphoma patients. And then really novel approaches for targets that are well developed, such as bispecific antibodies. Of course, we can think about the microenvironment, the immune microenvironment in particular, and think about therapies that might work on T cells, or perhaps even more excitingly, macrophages. And in particular, I'll talk a little bit about anti-47 approaches and targeting of SIRP-alpha. So as you can see, lots to be excited about, and in the category of antibody-based therapies in large cell lymphoma. So I'll start by talking about Tefacidamab. And so Tefacidamab, as you may know, is an anti-CD19 monoclonal antibody. It has an enhanced FC region, which really conveys, I think, some very important and unique properties, including an augmented ability for ADCC as well as ADCP. And so you see here that Tefacidamab may have multiple mechanisms of action, including direct cytotoxicity, but through interaction with immune effector cells such as natural killer cells and macrophages as well. So the very first study, we know single-agent Tefacidamab has some activity. The overall response rates are about a quarter in large cell lymphoma, similar in follicular lymphoma. And the point here is just to show you that even as a single agent, we can see some activity and have some capacity for durable responses, as is shown in the swimmer's plot. But really more excitingly is if we think about the engineering properties of Tefacidamab, this is really a monoclonal antibody that lends itself well to combine therapy with immunomodulatory agents such as lenalidomide. So recalling that lenalidomide itself has direct cytotoxicity in lymphomas, but also has an effect on the immune microenvironment, and increase in NK cell number and activity. This makes sense as a really, I think, a rational partner for Tefacidamab. And that's really what we studied in the L-MIND study. So this was a phase 2 study, a single-arm study of Tefacidamab plus lenalidomide. Interestingly, this was a study that had been powered actually to provide comparison to a historical cohort of len monotherapy in large cell lymphoma. And you see the study design here. These were patients who had been treated with 1 to 3 prior regimens. All of these patients were felt to be ineligible for high-dose therapy. And importantly, the study did not intend to include primary refractory DLBCL patients. You see this study schema here with the Tefacidamab given weekly for cycles 1 through 3, then every 2 weeks, essentially until disease progression. The lenalidomide being given for 12 months. So here are the initial efficacy data. So we see the objective response rate. We look at about 43% complete response rate. I would say in a population of second-line large cell lymphoma, that's quite impressive. If we add the partial responses here, we have about a 60% response rate. Importantly, if we look at PET-based CR, so really, that's, to me, everything in large cell lymphoma, you see that a high proportion of the complete responses were metabolic complete responses. And if we look across different subgroups, we can find that really the response rate seems to be consistent across different subgroups. Even the small number of primary refractory patients that actually did make it into the study. Here we look at the responses by depth of response. So if you see in the light blue colored line here, these are the 24-month follow-up data. You see that if you achieved a CR, the median PFS is not yet reached. So this is really quite impressive, I think, for a second-line population of patients, and especially appreciating that CR was a more common response than a PR. If we look at the PR patients, you can see here not quite as good a duration of response, and the median duration of response of 5.6 months. So here we actually see the progression-free survival curve on the top, and the median, and the overall survival curve. So the median PFS is 16 months, and the median OS is 31.6 months. So, appreciating that this is a population of patients for which we don't have truly a standard of care approach, second-line transplant ineligible, median PFS of almost 32 months, I think, is really quite impressive. What about safety? I think we have a population of patients that we may consider to be more at risk for toxicities of therapies that we give aggressive lymphoma patients. And I think encouraging to see here that, again, the safety profile seems to be manageable in such a population. Neutropenia was the most common high-grade treatment-emergent adverse event. And then we see here a smattering of serious adverse events, including infections that we need to be aware of. So, the L-MIND study really demonstrates that we have this combination of Tefacidamab, an anti-CD19 monoclonal antibody with lenalidomide, has a very promising clinical activity and the potential for durable CRs in what has historically been a challenging population to treat, where really we don't have a standard of care option. And based on these data, have been approved for treatment of patients with relapse refractory large cell who are not eligible for an autologous transplant. Of course, we want to study the Tefacidamab in different combinations. So as Martin mentioned, for example, in Europe, bendamustine is potentially a common pathway for second-line therapy, and so we have studies ongoing to look at Tefacidamab in combinations. Most importantly, I think the combination study I'm most looking forward to seeing is in the frontline setting. This is the first-line study that is ongoing, and we'll see some updated safety data from the phase 1 of that study. And this is a study of previously untreated large cell lymphoma patients with the comparators being Tafa plus R-CHOP versus Tafa-Len R-CHOP. So more to come from Tefacidamab. So I mentioned other anti-CD19 therapies, and I'll talk about that briefly, but I wanted to just reintroduce the idea of antibody-drug conjugates, which you all are familiar with. And so recall that we do have an approved antibody-drug conjugate, polatuzumab vedotin, also in transplant-ineligible large cell lymphoma patients in the U.S. This is approved in third-line space and beyond. And this is based on a median duration of response in a phase 2 study of about 12.6 months. This is a randomized phase 2 study with a comparator arm of BR, and you see the curves here, combination of Pola-BR being superior to BR in terms of progression-free survival with a hazard ratio of 0.36. So really kind of combining two concepts, an antibody-drug conjugate and CD19-directed therapy, we have Lonca. Loncastuximab tesirine is an ADC with a humanized anti-CD19 antibody conjugated to a PBD dimer. And as we described previously, CD19 is ubiquitously expressed in B-cell malignancies, including large cell lymphoma. So here are the results from the phase 1 trial. This was published in Clinical Cancer Research. And what you see here is that in the phase 1 testing, overall responses at doses greater than 120 milligrams per kilo were almost 60% with a high proportion of CRs. So I think, again, for a phase 1 trial, quite encouraging. And you see the duration of responses for the CR patients with a median not being reached. This has then been taken forward into the phase 2 study. And this is a phase 2 study of patients who had received at least 2 prior lines of therapy. And you see the study schema here. The overall response rate in the total population was 48%. And then if we look at different categories of large cell lymphoma, in particular, I'll call out the high-grade lymphoma. So these are the patients with double and triple hit by FISH. Again, we see a consistent response even in that subgroup. And actually in this population of patients, although the number is small, it's only 11 patients, all of the patients achieved a complete response. And so the median duration of response for this study was 10.25 months, as you see here. You see here, I think, fairly expected and manageable profile of adverse events. So some neutropenia, febrile neutropenia, although at a low rate, and then some abnormalities and transaminases. So based on these data, Lonca has been designated for priority review and will be, I think, likely to see this in the clinic sometime in the near future. So another anti-CD19 therapy. What about what's coming on the horizon? So I mentioned that we have several unmet needs in large cell lymphoma. So certainly we have lots of areas of active ongoing investigation. One area that I'm particularly enthused about are CD3, CD20 bispecific antibodies. So as Martin previously alluded to, these are being studied in lots of different lymphoma histologies, including indolent lymphomas. But several of these agents have reported some initial safety and even some efficacy data, including in large cell lymphoma. So I'll focus a little bit on Cinatuzumab, which was really presented at last year's ASH in the plenary session by Steve Schuster, and I'll try to focus really more on the large cell lymphoma population. So just recall, CD3, CD20 bispecific antibodies work by essentially engaging T cells and trying to activate T cells in the presence of B cells, and so in some ways, people have referred to this as sort of CAR T cell in a bottle, and the idea being that the mechanism may be a similar T cell anti-B cell response. The patients in the Cinatuzumab plenary that was presented last year, so this was a really large study. So for a phase 1 study, 270 patients. If we look at the patients with large cell lymphoma, they made up just shy of half of the patients in the data set. And importantly included, really, I think, for the first time, a reasonably sized population of patients who had been previously treated with CAR T cells, so about 10% of the population overall. And I'll focus on this a little bit later. Just to tell you about those patients, you can see here that those were really challenging patients, 5 lines of prior therapy, multiply refractory to a number of different therapies. So the safety looked quite good. We saw this last year, CRS, which can also be seen with bispecific antibodies as well as CAR T cells in about 30% of patients, but largely high-grade adverse events seem to be relatively uncommon, and high-grade CRS was extremely uncommon. Here you see the waterfall plots, and so you can see, again, at a variety of different doses investigated in the phase 1 trial, an overall response rate that's approaching 40%, with about half of patients achieving a CR. And keeping in mind that this is a phase 1 study, I'd say this is proof of some principle of activity. And then if we look really at some of these patients or subgroups of patients, what we can also see is that we can achieve some durable responses. So we see here in the swimmer's plot that the patients who achieved complete responses were able to maintain those even off therapy, and many of these complete responses were achieved within the first 8 weeks on therapy. So we can get early responses, they can be deep, and for some patients they can be durable. So certainly still lots to come and lots of questions to work out, but for a relatively large phase 1 clinical trial, I think certainly there's some exciting signals here. And if we just sort of take a look at this inset on the left, we'll see that, in patients who had aggressive lymphomas, whether that was third line and beyond large cell lymphoma or transformed follicular lymphomas, we can see, again, a consistent response across that group of patients. And then really, in some ways, a bit of an anecdote, but an important one nonetheless. I mentioned that there were about 30 patients in this study in whom there was efficacy data post-CAR T cell therapy. And interestingly, what you see here is one example of a patient who, what we're seeing here on the right side are the MIP images from PET scan, and you can see really had fairly extensive disease, and after 3 cycles of Cinatuzumab had achieved a PET-based CR. And interestingly, what you can see is an increase in the number of PCR copies of the CAR T transgene from baseline to cycle 3, suggesting that bispecific antibodies can work in patients previously treated with CAR T cells in probably both CAR T dependent and CAR T independent mechanisms. So again, more to come here, but shows some good promise. And then we'll just wrap with the last category of antibodies I wanted to talk about that are being studied in clinical trials, and these are agents that target CD47. So just to remind you all of the mechanism of these agents, so both healthy cells and tumor cells express CD47, which sends a "don't eat me" signal to macrophages. However, many times we want to sort of block this don't eat me signal. So cancer cells also express an eat me signal, which identifies them to be destroyed by macrophages. And so by blocking CD47, we can actually restore an eat me signal and allow macrophage anti-tumor activity. And CD47 is expressed on a wide range of malignancies, including B-cell lymphomas. And so this is the putative mechanism of action for anti-47 antibodies to block this don't eat me signal, resulting in an eat me signal and macrophage anti-tumor activity. So we've seen several different compounds to, I think, really be excited about, and when we think about novel antibody-based therapies in large cell lymphoma, including CD19, naked antibodies, antibody-drug conjugates. Talked a little bit about bispecific antibodies. We have several different anti-CD47 agents that are being studied. So really lots to come, and I think hopefully lots in the armamentarium to fill some of the gaps that we talked about.
Thanks, Krish. That was great, and really focuses on. Really highlighted a lot of these new options, but not only that, but a lot of these options are looking at different mechanisms, which is obviously really important in these folks who sometimes are in their third or fourth line of therapy. And so we have a question here coming in, and you mentioned this a little bit, but maybe you could elaborate a little bit about sequencing of antibodies in someone who progresses on CD19. Is there again, if you think about if we have some BiTEs and maybe some conjugated antibodies and CAR-Ts and they all target 19, is there a sequence that you should optimally use or one before the other?
Yeah, that's a great question. I think to this point, Nathan, it's one of the big questions about 19 therapies. So none of these trials have yet shown us a lot about 19 expression in patients that progress. And of course, I think the big question that comes up is, if I use a 19 agent early on and the patient progresses, can I still use a anti-19 CAR T cell? And so, I think in the follow-up from a lot of these trials, we're looking to see what happens to those patients and really understanding, what's the mechanism of relapse or progression will tell us a lot. So as of yet, I don't know what that optimal sequence is. I think a lot of times you have to make the best judgment that you can. So if you have a patient, for example, who's transplant ineligible, and you want to give them Tafa-Len, in some ways you're hoping they're going to be one of those patients that has a durable CR, and perhaps you don't have to give them the 19 CAR T cell, but this is a challenging scenario.
Yeah, that's good. And I think I have another question here, and it really reflects obviously what's on everybody's mind, I think these days, and it's again about COVID-19. A little bit different question in the prior session. Are we changing dosing or schedule of any of these drugs, CD19 or other? So not whether you would use CAR-T or not, but maybe, with some monoclonal antibodies, do you use a lower dose? And maybe I'll ask Karen, are you changing the way you deliver some of these drugs because of the pandemic?
So I think in large cell lymphoma, it's tough, right? Because this is a disease that we hope to cure with our therapies, and I wouldn't want to sacrifice curative potential. So it's a little different of a question, as you said, from follicular lymphoma, where you very well may leave out some parts of the therapy so that should a vaccine emerge, patients will be fit to get it. In this case, we push the envelope as much as possible in order to try to get patients to a definitive response. So I can't say that we've really changed our practice for these patients quite as much as we have for some of the incurable diseases we treat. Yeah,
I think for me at MD Anderson, it's pretty much the same way, right? If you've got a patient with life-threatening disease and you've got a potentially curative, or actually even if it's not curative, but if in the absence of therapy the patient has a very bad outcome, we have not been reducing dosage or extending schedules. Martin, I don't know, what is your experience pretty much the same in Germany or any differences?
I would talk pretty much in the same direction as Karen did. I think, there's something to gain, and you have to be cautious that you don't lose your efficacy because you're too cautious. The only exception may be that specifically in aggressive lymphoma, I would really consider to skip bendamustine, because we do know that it's specifically targeting your T-cell repertoire, and I would be a little bit cautious because I don't think it's a home run in aggressive lymphoma. So therefore, probably in these states, and so far we are lucky island, I would avoid bendamustine in aggressive lymphoma.
Okay. Boy, that's really good advice. So we're going to move on to obviously a very, very exciting therapy over the last, you could argue it's really transformed the way we think about dealing with patients with relapsed large cell lymphoma, and that's CAR T-cell therapy. And I'll turn it over to Karen Jacobson from Dana-Farber, who's going to talk about next steps.
Great. Thank you so much, Nathan. So we'll take the leap with CAR T-cell therapy and talk about where we are and where we're going. Like everyone else, we're going to start with a case. So this is probably one of the sickest patients I've ever treated. It was a 68-year-old man who was diagnosed with a triple-hit lymphoma. He received 3 cycles of R-EPOCH chemotherapy, and after an initial clinical response, by the end of cycle 3, he was progressing now both clinically and radiographically, and you can see his PET scan here. He went on to receive 1 cycle of R-DHAP and actually continued to grow through that. We treated him with an anti-CD19 directed CAR T-cell therapy. So I'll pause here and just ask the group, given his history, was CAR T-cell therapy the ideal option? And what would you have chosen? And also, what would you, I would ask another question, which is, given his disease burden at this point, what would you consider doing while the cells were being manufactured?
Mm-hmm. So that's a tough case. Yeah, these guys, these folks, especially that are progressing rapidly. I don't know, my experience, Karen, you could switch to other chemo, but unfortunately, once the pattern is set, many times so I would, at least for me, I think looking at novel or cellular therapy based options is the best thing for this guy. But maybe the bigger question is, how do you get him there, right? If you got 4 to 6 weeks before you make cells, Chris, what do you think?
Yeah, I mean, that it's really, really challenging, right? So these are patients that we often try to put on a clinical trial. We mentioned the bispecific antibodies. That's an immune-mediated therapy, as you mentioned, Nathan, a different kind of mechanism. So we've tried that and had some mixed successes, but I think this is a chance where you try what you can, and most often that patient's going to be in a trial while the cells are being made.
Yeah, and Martin, what do you for bridging, how would you, do you have, again, this is a guy progressing rapidly after two different chemo backbones.
I think this is a hard nut to crack, and we all have this experience with these rapidly progressing cases. It's almost desperate to catch on the disease in any ways. So I would not build on other chemotherapy regimens. To be honest, 10 years ago, I would say, well, what about Dexamine? Let's give it a try. But now we have other options. And I really would like to go for a targeted approach. And again, sorry for being boring, but in some of these patients, we have seen surprising responses to polatuzumab. So, and now we are in third line, so we are within the label. So that would be probably my first choice, knowing that if you start, get into the CAR T-cell treatment with a very high LDH, your chances for long-term success are significantly reduced.
Yep. So you guys hit all the nails on the head. So this gentleman threw us a curveball. So before we could collect his CAR T cells, he developed Fournier's gangrene and actually had to have a surgical debridement, which delayed collection, but he survived that and recovered from it. So we collected his CAR T cells and then gave him a cycle of polatuzumab, which really amounted to probably disease stabilization. And then when his T cells came back to us, we gave them back to him. And his 1-month scan is shown here, which was read as a partial response, but his 3 and 6 month scans have shown ongoing complete response. So he was definitely the sickest patient, but can show you what a single infusion of CAR T cells can do for a patient. So with that, I am going to just reintroduce everyone to a really, probably something you've heard ad nauseum at this point, but just an overview of CAR T-cell therapy and how they're made. So when we're talking about the autologous CAR T-cells that are available as standard of care these days, obviously you identify the patient with relapse and refractory B-cell lymphoma. You apherese that patient and recover their T-cells, and then they are re-engineered in a laboratory, usually using a retroviral or lentiviral vector to transduce the chimeric antigen receptor gene into the genome. And then the cells express the anti-CD19 CAR on their surface, at which point they come back to the patient's bedside and they're infused back into the patient after lymphodepleting chemotherapy, which is not intended to create an anti-lymphoma response or an anti-tumor response, but really to make the patient a better host for expansion and activation of their CAR T cells. So there are 3 clinical trials, pivotal clinical trials looking at CD19-directed CAR T cells in diffuse large B-cell lymphoma and other aggressive B-cell non-Hodgkin lymphomas. The ZUMA-1 study of axicabtagene ciloleucel, which is a CD28 anti-CD19 CAR T-cell therapy, the Juliet study of tisagenlecleucel, which is a 4-1BB CD19 CAR T-cell therapy, and then finally the Transcend study of lisocabtagene maraleucel, which is also a 4-1BB CAR T-cell. These were all given to relapsed and refractory aggressive B-cell non-Hodgkin lymphomas, many of whom had relapsed after prior autologous stem cell transplant. They differed in terms of how patients were allotted slots and then also whether bridging therapy was allowed on these trials. And as a result, you can see there was a differential in the number of patients who were enrolled on the trial at pheresis and then ultimately who were treated. But a very high proportion of patients who did go on these studies ultimately got their CAR T cells back. And the ZUMA-1 and the Juliet study has led to FDA approval based on the fact that they yield responses in anywhere between 50 and 80% of patients and complete responses in about 50% of patients. And as we know, and we'll talk about outcomes in the next couple of slides, these responses can be durable in about 40% of patients. We are awaiting the results, we've seen the results of the Transcend study, which has similar efficacy, and we're awaiting the FDA review of that study for possible third anti-CD19 directed CAR T-cell therapy in the standard of care setting. So let's look at these studies a little bit more closely. So on the ZUMA-1 study of axi-cell in relapse refractory, or just actually refractory large B-cell lymphoma, there were 7 patients treated in phase 1 and then 101 patients treated in phase 2 at the recommended phase 2 dose and lymphodepleting chemotherapy regimens. The first cohort was large cell lymphoma, and the second cohort included primary mediastinal and transformed follicular lymphoma patients. Everybody got the same dose of axi-cell, and as had mentioned before, 99% of patients who were enrolled had axi-cell successfully manufactured, and 91% of patients who were enrolled were dosed. And so here you can see the long-term follow-up. This is really the 2-year data for the ZUMA-1 study with a median follow-up of 27.1 months. And as I mentioned before, about 80% of patients are responding and 58% of patients achieve a complete response. And as you can see from these progression-free and overall survival curves, a lot of what happens to these patients in terms of either relapse or lack of response happens early in the first 3 to 6 months. And once patients maintain their response, hopefully like the patient I presented at the beginning of this talk, many of those patients maintain their response, which amounts to about 40% of patients having durable responses. And if we look at how your response affects progression-free survival, clearly patients who achieve a complete response are among the patients or a partial response are among the patients who do the best, as opposed to patients who have stable disease, which is really not surprising. And this is just based on updated data from ASH last year with the 3-year response and survival information. Thinking about patients who, looking at patients who were leukapheresis for standard of care axi-cel. This is one of a couple of different real-world analyses that we've seen since axi-cel has been FDA approved, in all of these real-world experiences, we see that probably about 60% of these patients would not have been eligible for the clinical trials based on medical comorbidities or other aspects of their performance status or their disease. But when we treat these patients with axi-cel in this setting, we're seeing very similar progression-free and overall survival and very similar response rates and toxicity profiles as well, which is actually very reassuring, because there was some concern initially that this was a cherry-picked population, and maybe these results wouldn't apply to all patients that we treat or would want to treat. We have a follow-up to this. So the CIBMTR is collecting data on patients treated in the commercial setting in the United States and beyond. And we have data for the first 533 patients that were reported to the CIBMTR since axi-cel's FDA approval. They looked at specifically patients who were under 65 versus over 65 to see if there was any difference in outcomes. Again, these patients were a sick population, very similar in terms of prior therapies to the ZUMA-1 study. But you can see that there were some patients who had higher ECOG performance status, and this included an older population. And when we look in the CIBMTR registry, again, you're seeing that progression-free survival and overall survival are very similar to what we saw on the ZUMA-1 study, and it actually is not impacted by age, so older patients do just as well as younger patients, and maybe even potentially a hair better. Important data, again, justifying the use of this more broadly in our clinics. We'll switch gears and talk about tisagenlecleucel based on the results of the phase 2 Juliet study. So here's just a schema of the study, very, very similar to axi-captogene ciloleucel. Some differences in terms of how patients were enrolled and then had their cells manufactured. There could be some delay there because on this study you send frozen cells to the lab to be manufactured, so those cells could wait and didn't have to go into manufacturing right away. These patients were allowed to receive bridging chemotherapy, and then when the cells came back, they were treated again with lymphodepleting chemotherapy, followed by their tisagenlecleucel infusion. They had pretty similar inclusion criteria to the ZUMA-1 study in terms of performance status and prior therapies, and you can see the range of cell doses that was given on this study. And when we look at progression-free and overall survival, similar to what we saw on ZUMA-1, you can see that for all patients, about 40% of patients are alive and without disease recurrence at a year or beyond. And obviously, these numbers look better for patients who achieved a complete response following their tisagenlecleucel infusion. And similarly, we're starting to see some real-world data out of the CIBMTR for the first 80 or so patients that were reported since tisagenlecleucel's FDA approval for aggressive B-cell non-Hodgkin lymphoma. And we're seeing similar response rates, best overall response rate of 58% and a CR rate of 40%, and very similar progression-free and overall survival curves, which is again reassuring because as you expand eligibility criteria in the commercial setting, we are not seeing a detriment in efficacy. There have been some comparisons of axi-captogene ciloleucel and tisagenlecleucel in this commercial setting across different centers, I think what we're seeing is very similar outcomes. It's very hard to look across these studies and compare. We're not treating the same patients with axi-captogene ciloleucel as we are with tisagenlecleucel, in part because of how differently the different amount of time it takes to get the cells back to the patient, and also because of some of the safety issues that we'll talk about in a couple of slides. So I would compare these with a grain of salt and just say that overall we're seeing similar efficacy across the board. And then finally, the last study looking at a CD19 CAR in relapse refractory large cell lymphoma is lisocabtagene maraleucel on the Transcend NHL 001 study. These patients also were allowed to receive bridging therapy between their leukapheresis and their lymphodepleting chemotherapy, but all patients were restaged with a PET scan if they did receive bridging therapy prior to lymphodepletion. This study was designed initially not necessarily to be a pivotal phase 2 study, so there were many different histologies and many different dose levels explored, as well as dosing schedules. But eventually, it was the recommended phase 2 dosing schedule and dose were arrived at, and those and then there was a pivotal cohort defined based on their prior diagnosis and to match really what was done on the Juliet study and the Zuma 1 study. And so those are the populations that we're going to look at in the next couple of slides. So if you look at response rate, again, really high response rate, 73%, with a CR rate of 53%. We look at duration of response, we're seeing that if you achieve a complete response and maintain that response out past 3 to 6 months, you have a very high likelihood of continuing that response out past 1 or 2 years. And similarly, when we look at the progression-free and overall survival curves, we can see that about 40% of patients overall are alive and without disease response out past, again, 12 or 24 months, and a greater proportion of patients whose best response was a complete response. So how is CAR-T sort of shaping cancer care for our lymphoma patients in 2020? So if you have a patient who's found to be eligible for CAR-T cell therapy, specifically patients with aggressive B-cell non-Hodgkin lymphomas who have relapsed after 2 or more prior lines of therapy, those are patients that we are, that this is an option for, and who didn't really have great options before. We know that from the Scholar 1 study that this group of patients really had a median overall survival probably of about 6 months. It's important to know who we shouldn't be treating with CAR T-cell therapy, and of course, we do worry about treating patients with active infection or inflammatory disorders. Those are patients who definitely have increased toxicity and are at increased risk of fatal outcomes from those toxicities. It's important to refer patients who you suspect for CAR T as good candidates for CAR T-cell therapy to specialists or an expert center. When the patient does get there, if they are deemed to be eligible, they will have their CAR T-cells collected. They will get lymphodepletion prior to CAR T-cell infusion, and then after their CAR T-cell infusion, either as an inpatient or very closely as an outpatient, they're watched for cytokine release syndrome as well as neurologic toxicity. And if patients do develop neurotoxicity or cytokine release syndrome, there are specialized ways to manage that, including IL-6 receptor antibody therapy and steroids as needed. And then when the patient finishes sort of their acute CAR T-cell period, there are some things that we need to monitor for, specifically, obviously, relapse and recurrence, but also we know that about a quarter of these patients develop long-term cytopenias and need transfusional support or GCSF support. And obviously, these patients develop B-cell aplasia, specifically when we're using CD19-directed therapies. And so we need to keep an eye on immunoglobulin levels and risk of infection. So let's talk a little bit about that acute period in terms of when patients are at risk for cytokine release syndrome and neurologic events. So it's pretty well displayed on this slide over here. Obviously, for cytokine release syndrome, we're worried about sort of for low-grade patients, we're worried about flu-like illness where patients develop fever and body aches and fatigue and malaise. But if it progresses, patients can develop capillary leak, which can lead to hypotension or hypoxemia, and obviously this can put a stress on the body and lead to end organ dysfunction. And in its extreme form, cytokine release syndrome can precipitate an HLH or macrophage activation syndrome-like picture. Thankfully, that's rare, but it can happen. And largely, cytokine release syndrome mirrors the expansion of CAR T cells upon reinfusion. And so, with our CD28 CARs, it can start as early as 1 to 2 days after CAR T cell infusion. And for the 4-1BB CARs, it's usually more like 4 to 6 days after CAR T cell infusion. And it generally lasts about 3 to 7 days, depending on the duration of CAR T cell expansion, at which point the inflammatory syndrome can generally correct itself. And then what happens towards the tail end of cytokine release syndrome is the second toxicity we worry about with CAR T cells, which is the neurologic toxicity, or ICANS. And this can present with very mild confusion, and very often patients develop an aphasia where they really have a difficulty understanding language and speaking clearly. But largely, these patients are awake and alert. They're just unable to interact with the world around them. We worry very much when the patients become sleepy and somnolent, and we worry about airway protection, and then of course worry about the inflammation that happens in the brain in this setting and its potential for causing cerebral edema, which could be a fatal complication, as well as seizures. So this usually starts somewhere between day 5 and 8 after CAR T cell infusion, and its duration is actually more variable. So for some patients, this can be a couple of days, but for others, it can be upwards of 1 or 2 weeks. But thankfully, outside of some of those fatal complications that I alluded to, both of these toxicities are self-limiting, and patients will recover to their normal mental status and leave the hospital in fairly good cognitive shape. So thinking about the rates of these toxicities, they do differ across the different clinical trials. And I think with the CD28 CARs, a greater proportion of patients will get any grade of cytokine release syndrome, and often a higher grade of cytokine release syndrome, as shown here on the ZUMA-1 study compared to the Juliet and Transcend studies, which remember are 4-1BB CARs. But I would take the rates of grade 3 and higher CRS on the Juliet study with a grain of salt, because they do use a different grading schema, which upgrades grade 2 CRS to a higher grade CRS. And then similarly, the CD28 CARs lead to a higher rate of neurologic toxicity, as well as grade 3 or higher neurologic toxicity. And we'll talk about what these grades look like on the next 2 slides, compared to the 4-1BB CARs on the Juliet and the Transcend study. So thinking about how I treat CRS, I think cytokine release syndrome is, we won't go through all of the different grading, but I think very simply, grade 1 CRS is fever alone, grade 2 CRS is fever plus fluid responsive hypotension, or patients who need a low dose of supplemental oxygen. And then grade 3 CRS includes patients who really need the ICU because they need pressor support or more respiratory support. And then finally, grade 4 CRS is the CRS that requires mechanical ventilation and where there's evidence of grade 4 or higher end organ toxicity. And so thinking about how to treat these patients, and for grade 1 CRS, we generally just observe if patients have high fevers for more than 3 days, we consider giving tocilizumab, the IL-6 receptor antibody, just to make them feel better, but not necessarily to change their treatment course. Whereas for grade 2 and higher CRS, we generally are giving tocilizumab with or without a dose of dexamethasone in order to try to prevent escalation to higher grade cytokine release syndrome. Definitely for grade 3 CRS, we are giving patients tocilizumab with dexamethasone, and if they are unresponsive, we then move on to high-dose Solumedrol. And for all patients with grade 4 CRS, we're using high-dose Solumedrol. And then in terms of neurologic toxicity, again, I'm not going to go through every single one of these grading schemas, but generally how I think about it is that grade 1 are patients who are mildly confused but can still do their instrumental activities of daily living and activities of daily living. For grade 2, patients lose their ability to do their independent activities of daily living but can still do their ADLs. And then grade 3, it's such severe confusion that patients lose their ability to do their ADLs. And then finally, for grade 4, neurologic toxicity, these are really life-threatening, where we're worried about seizures and airway compromise and a need for mechanical ventilation. For grade 1, we generally observe. For grade 2, if they occur early, I worry more about them and generally would consider treatment with dexamethasone. If it happens later, which is usually after day 5, I would continue to consider observing them, although no one would say dexamethasone is the wrong choice in that setting. And then for grade 3, neurologic toxicity, we always give dexamethasone. And finally, for grade 4, again, just like CRS, we would give this patient high-dose Solumedrol. So where are we going for CAR T-cell therapy in diffuse large B-cell lymphoma? One major question is whether this is potentially a better therapy for patients with relapsed or refractory disease than auto transplant, specifically in the primary refractory and early relapsing setting. And so there are several phase 3 trials that are testing this versus auto transplant in large cell lymphoma. There are the Belinda study using tisagenlecleucel, the Zuma-7 study using axicabtagene ciloleucel, and then the Transform study using lisocabtagene maraleucel. All of these studies are using patients with either primary refractory or early relapsing disease, and their primary endpoint is event-free survival. And these are ongoing studies, and we are eagerly awaiting the readouts. And then what about moving CAR T cells into other B-cell non-Hodgkin lymphomas? So specifically in indolent B-cell non-Hodgkin lymphoma, we'll see at this meeting the updated results of the Zuma-5 study. But based on what we presented at ASCO last year on 125 patients with follicular lymphoma, and at the time it was 16 patients with marginal zone lymphoma, all in the 3rd line and beyond, treated with the FDA-approved dose of axicabtagene ciloleucel, we can see that about 93% of patients responded and about 80% of patients had a complete response. And this was similar in follicular lymphoma and marginal zone lymphoma. And when we look at the duration of response, specifically in follicular lymphoma, because the marginal zone lymphoma follow-up was very premature, but in follicular lymphoma, you can see that at the median follow-up, which was 15.3 months, about 70 to 80% of patients are maintaining their response. And there were some patients that did have an initial partial response that ultimately deepened their response in subsequent follow-up. So some of the take-homes of CAR T-cell therapy in lymphoma, obviously anti-CD19 directed CAR T-cell therapy is leading to durable remissions in about 40% of patients with relapse and refractory aggressive B-cell non-Hodgkin lymphoma. And there are emerging indications in, as I showed you, indolent B-cell non-Hodgkin lymphoma, but what we didn't talk about today was in mantle cell lymphoma as well. And the use of anti-CD19 directed CAR T-cell therapies in the commercial and real-world setting has yielded really similar rates of response as well as toxicity in a broader population than would have been eligible for the clinical trials, which is reassuring that this therapy has potency and can be given to more of our patients. And then finally, enrolling clinical trials are including some new products and new combinations and some new indications and lymphoma subsets. And they're really aimed at thinking about overcoming resistance, and that's specifically using some combination therapies like checkpoint inhibitors with CAR T-cell therapies, or CAR T-cells that actually target two or more antigens to try to avoid or an escape mechanism of antigen loss. And also thinking about prior therapies for patients and how they affect the CAR T-cell product. That is an emerging interest and on people's radars now as we think think about sequencing therapies for our patients. We obviously want to do better with toxicity, and so there are lots of trials looking at drugs to target the mechanisms of action of some of these toxicities and using them prophylactically to try to improve the safety profile. And then finally, overcoming access. These are expensive therapies, and as we discussed with the patient at the outset, the manufacturing can take 3 to 4 weeks, and some of our patients can't wait that long. And so off-the-shelf products are in clinical development right now and in clinical trials, and can really make a difference for our patients who can't wait for this therapy. So with that, I will turn back to the panel. Thank you.
Thanks, Karen. Obviously these therapies have made a huge impact, but what was really neat is all the things coming down the pipe. So I think we'll be hearing about CAR T cell type therapy, it sounds like, for many, many more meetings, hopefully in person. So I think we have just a couple minutes here for some questions, and looks like some of these you've talked about, again, is salvage refractory. You mentioned about what's the typical onset for CRS. Well, this is kind of a good question. How can we prevent or mitigate CRS or neurotox with CAR T? Are there, again, before it happens, any strategies to maybe identify people who might get it? Or
yeah, so as we've learned from, I think in this field you can learn from every single patient, and as we've learned from patients who have been treated, there are some key mechanisms, or at least associations, with risk of CRS and neurotoxicity that have been elucidated. And we know that really the monocytes, or actually the activation of monocytes by CAR Ts, tends to be a really important factor in developing these toxicities. And so there are trials looking at anti-GM-CSF antibodies to actually kind of dampen down that monocyte activation, so that to see if that can mitigate some of these toxicities. People are looking at the use of IL-1 receptor antagonists like anakinra, or direct IL-6 antibodies like ciltuximab to be given prophylactically. And then also we know that there is a great deal of sort of endothelial injury and activation that happens in patients who develop neurologic toxicity in particular. And so there's been some interest in looking at some of the endothelial stabilizing agents like defibrotide in this setting. So I think that might be next year's meeting to see how some of those prophylactic strategies impact these side effects.
Thank you, guys, and enjoy the meeting and have a great day.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/DJX860. This activity is supported by educational grants from ADC Therapeutics, Epizyme Incorporated, Incyte Corporation, Kite, a Gilead company, and Morphosis US Incorporated.